Now we're going to talk about some key considerations in prescribing. Opioids are associated with several different prescribing parameters that must be talked about. So we're first going to talk about what you need to do prior to prescribing opioids. Second, we're going to talk about different routes of delivery. Then we'll talk about regulations and laws related to opioids. Then we'll calculate MMEs and talk about calculations for opioid rotations. We'll talk about withdrawals and tapers and overdoses and using naloxone and when to use naloxone. So prior to starting opioid therapy, you always want to discuss with patients the risk and the benefits of therapy. You want to ask about the patient's functional goals, family, and impact on the therapy on their family and their life. You always want to consider if the patient has any psychosocial or behavioral factors that may affect treatment. You want to always consider other therapies whenever a patient has an active substance abuse disorder, elevated suicide risk, a true allergy to opioids, or if they have concomitant use of benzodiazepines. This opioid risk tool can be used to help identify patients who might be at high, moderate, or low risk. This is just for your information, but it is a good tool to try to figure out whether or not a patient is at a higher risk versus a lower risk of having opioid divergence or opioid abuse. Another thing to consider are the different routes of delivery. Opioids can be given via different routes, including IV pushes, where you might see this as hydromorphone 0.5 milligrams Q 6 hours PRN, where the nursing staff can give IV pushes, so put the drug into the IV, push it in there, every 4 to 6 hours to ensure proper pain management. This is different than continuous infusions, where the patient gets continuous drugs through a drip over a long period of time. Now, I say a long period of time, but a much longer period of time compared to the pushes. This is primarily used in the ICU, and it's used for both analgesia and sedation. You also have what's called patient-controlled analgesia, and the reason it's called this is because the patient will be holding this little button here, and then whenever they press the button, they can get a small dose of opioid. Your routes of delivery can also include epidural and intrathecal routes. And for oral therapies, immediate release, extended release, and abuse deterrent opioids. There are several laws that govern the use of opioids, including in the state of Virginia. Number one, the state of Virginia does state that you should not use more than 7 days of opioids in patients that have acute pain or are post-ED discharge. If you do extend past this deadline, then you have to give written documentation of such. Similarly, the cutoff for post-surgical patients is 14 days. Your prescription strength limits listed here are 15 morphine milliequivalents. You have to have a documented reason in the medical record for prescribing above that. And then greater than 120, you have to have reasonable justification and refer to a consulting pain specialist. Over here, you'll see the prescription drug monitoring program. You are required to check it every single time you have a new opioid prescription or you change the dose. Virginia opioid prescribing laws also tell you that you should co-prescribe naloxone if the patient has a history of a prior overdose, substance abuse, using doses in excess of 120 morphine milliequivalents per day, or concomitant benzodiazepines. All those agents should receive a naloxone prescription. And we'll talk a little bit about different versions of naloxone here in a moment. It also says you shouldn't provide co-prescribed opioids with any of these medications, including cardisoprolol, tramadol, and benzodiazepines. And if you do allow it, it has to be an extenuating circumstance, and you have to document a tapering regimen or a plan.